Hi, welcome to our program. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. And our program, Digital Slide Review and Sign Out, is a joint venture, part of the Digital Anatomic Pathology Academy, which is a joint venture of the Digital Pathology Association and Path Presenter. We're very grateful that you've come to spend a few minutes with us as we talk about an interesting case today having to do with the GI tract. The patient is a middle-aged person, up in their 40s, and they've been experiencing some degree of weight loss, a little bit of anorexia, and some discomfort, epigastric pain. Well, those are fairly non-specific symptoms, but certainly indicate that there may be something of significance going on that's interfering with the normal functioning of the GI tract. So just for fun, given this modern era, I thought, let's see what artificial intelligence might suggest as a differential diagnosis if we were to feed that set of symptoms and that patient age into the algorithm. What kind of differential diagnoses might we come up with? Well, not unexpectedly, it includes a variety of enteric disorders ranging from ulcer disease, inflammation, pancreatitis, inflammatory bowel disease, malignancy, as well as a number of metabolic disorders, including diabetes, hyperthyroidism, and malabsorption syndromes, and obviously psychiatric disorders like anorexia and depression, and not to be overlooked are possible infectious causes as well. So I think it's going to be a day or two before that set of symptomatology can give you the exact diagnosis, of course, but it does give you some ideas about things that you should consider and where you might be heading with this kind of a disorder. Our patient proceeded to endoscopy, and on examination of the stomach, this was what greeted the gastroenterologist. Very large, exaggerated rugal folds, primarily involving the proximal stomach, the body, and fundus. So this had the appearance of a very hypertrophic gastropathy with giant rugal folds. And the differential diagnosis for that syndrome or that sort of scenario would include a number of different entities, including Zollinger-Ellison syndrome, some hypergastrinemia, Menetrier's disease, hypertrophic lymphocytic gastritis, various hypersecretory gastropathies, and then things which usually are more localized, but may on occasion have the appearance of hypertrophic polyps like benign, hyperplastic polyps, or some types of related neoplasia that may arise from those settings. So that is, I think, a useful differential to remember that these three primarily would fall into the category hypersecretory gastropathy, quite unusual, but also would fit into that category on occasion. Actually, none of these three entities or four entities are particularly common, but can be seen in rare occasions. So let's turn our slide around here and see what we're going to be dealing with. This representative slide came from a resection specimen, which on occasion can be required to deal with this syndrome. But as we can see at low magnification, we have normal thickness to the wall, nothing going on in the submucosa, but then these very exaggerated folds that make it look very, very tortuous and complex. But here at the base of this, you can see that there is this fairly prominent foveolar hyperplasia. It's about 50-50 between the glands of the parietal and chief cells versus the foveolar surface mucosa. So that's just in the basal state. And then as we look up above here, we see this is even more exaggerated And in some areas, it may be more like 70-30 or even higher. And then we have these sort of secondary changes with some altered architecture, very pronounced dilated areas of glandular tissue, and then even some areas of maybe ulceration or dense inflammation associated with edema and some granulation type tissue. Um, Looking a little bit further, we can see that there'll be areas where, let's see if I could find it here. Areas where the smooth muscle of the lamina propria, or excuse me, the muscularis mucosa gets kind of pulled up into the glandular tissue. So here you can see that this smooth muscle is a very irregular boundary and is getting pulled up into the um, oxyntic mucosa in areas. So you do have some sort of smooth muscle engagement in this process. And then just very bland cytology to all of these very exaggerated hypersecretory glands. The nuclei are very benign, basal appearing down at the base of the cell, but just overstimulated tissues sending out tons and tons of secretion. So you can see then if there's a fair degree of protein or other nutrient content to this type of tissue, how this could create a protein losing enteropathy and leading to weight loss and so forth. And here again, you can see this smooth muscle caught up into this area. Now, I think the other interesting thing to look at here is the overlap. If we had an area like this, for example, and our biopsy was just very, very superficial, we might think that this was an inflammatory polyp or maybe a juvenile polyp potentially with cystic dilated glands and edematous stroma and so forth. But in fact, this is just sort of an inflammatory type reaction associated with the Menetrier's disease, with the hypertrophic gastropathy that we're seeing. So there can be some overlap depending on the size of the sample that you're given. You may be thinking ulcer, you may be thinking hyperplastic polyp, inflammatory polyp, or other types of changes, when in reality the process is quite diffuse, and that moves it nicely into the category of a hypertrophic gastropathy such as Menetrier's disease. So what is Menetrier's disease? Well, it's usually found in men in their mid-adult years. It's a very hypertrophic and protein-losing gastropathy that involves the body and fundus predominantly. It's marked by tremendous foveolar hyperplasia and then a relative amount of oxyntic mucosal atrophy, some vertically streaked smooth muscle getting pulled up into the mucosa, as we've indicated. And more recent investigations seem to indicate that there's a role for TGF alpha and EGFR signaling. And this is important because this may help us to transition this to a non-surgical disease because there are some newer targeted treatments that interfere with these pathways and this signaling so that the patient can avoid surgery and can actually potentially get restoration of normal functioning in their stomach. So we mentioned there's a number of things in the differential, and here is just a nice breakdown. As you can see, these that we've mentioned, Menetrier's disease, hypertrophic lymphocytic gastritis, hypersecretory gastropathy, and Zollinger-Ellison syndrome, are all very diffusely located and primarily in the body and fundus. They, particularly Menetrier's and hypertrophic lymphocytic gastritis, are pretty exclusive to the foveolar epithelium, and that is very useful. Whereas Zollinger-Ellison syndrome tends to provoke a hypertrophy of the parietal cells because of the hypergastrinemia. And then there can also be endocrine cell hypertrophy in the other areas of the stomach. Now, in contrast, the hyperplastic polyp or the inflammatory type polyp changes, those tend to be more towards the antrum. Again, they involve foveal epithelium, but there's also significant distortion and the edema and those sorts of things that we've seen. The other considerations, adenocarcinoma, those sorts of things would be less frequent and would have the characteristic features of those findings. Looking at this from another standpoint, based on the study by Hu et al., very nice comparison of the particular features of different components of the architecture and how those might be contrasted with these contrasting entities, which should fit somewhat together, as we've indicated. And this would be more directed towards kind of biopsy pathology, if you will. Noting here that with Menetrier's disease, you should see some degree of atrophy of the parietal and chief cells proportionately, but with hyperplastic polyps and juvenile polyps, you won't see that. And other features here that you can study this at your leisure. I don't want to make a big deal about this chart per se. So our final sign-out diagnosis on this case is Menetrier's disease, and the treatment was a partial gastrectomy in this setting. We hope that helps you as you consider some of these hypertrophic gastropathies and look at those cases in your practice. If you have questions or comments, please don't hesitate to reach out to me. And we do hope that if you like this, you'll hit that like button, subscribe, click the notify button so you can catch word of new releases on our channel as they become available. Thank you so much for joining me and being with me for this interesting case discussion of Menetrier's disease today. And so until next time, may you be well, and thanks so much for joining us.